If you could change something about your face, would you? For some, it's a small tweak. For others, it's life-changing. Today, I'm joined by Dr. Cameron Chesnut, renowned facial plastic surgeon. He creates masterful outcomes for his patients while incorporating regenerative medicine and advanced recovery techniques. We're going to explore what's possible in facial plastics. I'm Dr. J. Rutland, and this is the Health Exchange. Let's get into it. Dr. Chesnut, can I call you Cameron?
Absolutely.
Please call me Jamie. I don't know if you know this story, but do you know when we first heard about each other?
Sure.
What was your experience? I mean, I know we have a mutual
We
friend.
have a mutual friend, yeah.
We had just moved to Orange County, my family. My kids at the time were like 2.5 and like 4 months old. And I was supposed to be in David's wedding.
Oh.
Our moving truck didn't get to our house, so we didn't have anything in the house. And my wife looked at me and she was like, I don't think we can go to this wedding.
I heard about this.
And David still hates me to this day because I didn't make it. I called him and I was like, David, listen, I'm sorry. I'm not going to be able to make the wedding. I can't make it. And he was like, oh, that's cool. Cameron will do it.
Yep, exactly.
That's
the story. That was the fill-in.
Yeah. I was like, who is Cameron? So like, who is Cameron? What drew you to where you are today?
Yeah, well, you've been up in my neck of the woods. I'm up in Coeur d'Alene, Idaho, Spokane, Washington, and I'm a facial plastic surgeon, as you sort of mentioned, but I have a very unique practice. All of my patients travel to me from all over, about 30% international, 70% from the United States. And then it's like a retreat type of setup. They come in, they have their procedure, they stay in like very curated recovery area. It's almost like a wellness retreat, from hyperbaric oxygen to views of water. We're very, very sort of thoughtful about how we structure their recovery. And personally, I prepare and train like an athlete would. I love that mindset of get ready, execute, and recover. And I do the same for my patients. So they start getting ready to come see me months before they come. They have their time with me, and then they have this very extensive recovery protocol afterwards. It's heavily regeneratively medicine based, as you sort of mentioned.
Yeah, I have an understanding of it. But one of the questions I have for you is, was there a patient story where that derived from, or why you are like that in terms of the experience and how to establish that where you did in Coeur d'Alene?
I had one very early on, and she was a performer and had been through a bunch of things leading into me. I was sort of a rescue at that point. She'd had a lot of prior devices and hyaluronic acid fillers, like kind of a lot of entryway things. And then she led into a procedure that was the wrong procedural choice for her. It was kind of too big for what she needed. And she found herself in a place where she kind of didn't recognize herself anymore. And what she helped me understand was what the like entry level things can do, how powerful they can be, for better or for worse. And she also taught me about what it means to not look the way that you feel very early on. That's probably one of the most common things that I hear now. But this sort of mismatch, this neurocognitive dissonance that gets created when you see something that isn't you. I try to take a very minimally invasive approach to the procedures that I do, and seeing how that changed her for the better and just kind of brought her back to matching again was a very, very powerful lesson early on for me that has driven a lot of my practice since then.
It's interesting that you say the word matching, because for me, when I think of matching, I think of symmetry, which is really what plastic surgery is about, right? It's about symmetry. But the other thing that you do actually really, really well, and I know you know this in terms of matching, is you sort of match the outside with what's going on inside, which is where regenerative medicine comes into play, right?
Absolutely, yeah.
And I appreciate that. I've appreciated that so much. And again, I haven't told my audience this yet, but I'll tell you, I'm actually taking the anti-aging regenerative medicine boards, the A4M, in December.
Yeah.
Just to be able to apply that to my practice of pulmonary and critical care. But for your practice of facial plastic surgery, from a surgical perspective, what are the 3 common procedures that you perform? And I recognize that question can be a little bit too broad for somebody as detailed as you, but
sure. If we get into facial plastic surgery, it gets divided into reconstructive procedures, and we can all imagine what that is. That's everything from dog bites to accidents to cancer reconstructions, things like that. And then there is the thing that people tend to think about most, I think the sexy, that's the cosmetic things, right? And in the cosmetic things, I like to divide it into regenerative or rejuvenative types of things, which is just anti-aging. And then there is transformational types of things. To me, a rhinoplasty is a transformation. It's changing your nose into something that you didn't have before. quite literally transforming it. And so very simple, beautiful, intricate procedure, but that's not the type of things that I do. I do no transformational work. I only do rejuvenative or regenerative types of work. So I'm an aging face person. That means I do brows, eyelids, faces, and necks, those types of things.
And so when you're doing those types of procedures, the types of things that you're doing, are you removing fat? Are you manipulating fat?
I'm doing a lot with fat. Yeah. It's a lot of soft tissue regeneration, right? And so fat is what we all like. We think of skin and fat. Those are probably the first things we think about in our face. Muscle plays a key role as well, but skin is the one we all see. That's kind of the first place a lot of people go. And it's a great first place for people to go, is rejuvenate your skin. Easy. It doesn't have to get too intense or too complicated to do that. But the layer right underneath that is our fat pads. And our fat pads in our face, they're beautiful. They're a mix of form and function. They give us the shapes and contours that make us youthful, but they also serve as glide planes so the muscles can slide by each other. So I think of them for what they are. They have two purposes: to shape and to allow a glide plane. So I don't want to disrupt those things, but I'm heavily, as you said, manipulating fat pads by adding fat to them, which I'll borrow from other parts of the body, and I'll concentrate down to the kind of high quality stem cell dense version of fat. Our fat is a beautiful source of mesenchymal stem cells, MSCs we call them. And so I use that. I leverage that to rejuvenate the face and to add volume where we've lost volume in our fat pads. And so if I were to like really just Reader's Digest version, what a lot of my practice is, it is putting fat pads back where they came from. It is making sure that they are strong, structural, and appropriately volumized when I do that. So it's very simple, and I'm trying to find the least invasive ways to do those types of things.
Those are surgical techniques. Do you do or perform any non-surgical techniques?
I do. The first couple of things I mentioned, actually, when we talk about addressing the skin, a great first place to go, that's non-surgical usually. And that can be everything from, I would say, microneedling with growth factors, which is often your own platelet-rich plasma, PRP, or exosomes, which we might talk about a little bit. Those are regenerative medicine light mixed with a very light modality of essentially poking a lot of holes in your skin, causing a little injury, then helping it heal. And that steps all the way up to things like lasers, which are light-based devices that do the same thing. They use light to target something very specific in the skin, which is one of the beautiful parts of lasers. We can be very specific with our target, but they're causing an injury, and we're trying to help that injury regenerate in a strong way to build more collagen or build more elastin and add some life back to the skin. So
and you're targeting different areas of the skin, or different, I guess, depths of the skin based on wavelength with the laser?
Exactly, yeah. The wavelengths get very specific for parts of the skin. So if we want to target blood vessels, we can get a wavelength that's very specific for a red blood cell. If we want to target collagen, we can target collagen. If we want to target pigmentation, we can target pigmentation.
And when you target those areas, what specifically are you trying to do with targeting that area?
So in the sense of rejuvenation, we are trying to take broken down collagen and elastin, and we are trying to remodel and recycle it a little bit. Because if we looked under a microscope at somebody's skin, regardless of skin tone, we will often see how much sun damage has added up over the years, and we can see broken down collagen and elastin under the skin. We have ways to regenerate and remodel that, but we can upregulate those pathways via using something like a laser to do that. And it's very, very powerful to do those types of things.
So when a patient comes to you for a consultation, how do you decide between surgical and non-surgical techniques?
I'm usually mixing them together. It's rare that I'm doing a surgical procedure without using non-surgical modalities with it. And that would be laser, fat transfer that I talked about as a non-surgical option. Almost always I'm doing those with my surgical procedures because either one is incomplete without the other to be comprehensive.
And so are you doing the non-surgical before the surgical, or are you doing the surgical and then you wait and then you come back in?
All happening at the same time.
All happening at the same time.
Exactly.
It's one of the things that I noticed in your practice is you take into account kind of the microscopic aspect of cells and what the body needs to sort of operate efficiently, effectively, and optimally.
Mm-hmm.
Where did that come from, and how do you incorporate that into your practice when you see a patient for the first time?
Yeah. Well, the real drive here, if I were to get into it, is like sort of an obsession with my results. If I'm going to be truly honest, it's like I want the best results that I can get. And as I've grown up, I'm going to say, in my practice, I've also evolved to just like have really genuine connections with my patients. These are relationships that I highly value. And so I'm very choosy with who I work with in a very positive way. And once we're rolling with them, the relationship starts before they come. So sort of like you were saying, the interest in cellular optimization, that's actually a really good way to say it. That would be a beautiful, synonym for regenerative medicine, is I want their cells to be functioning at the highest before they come see me. And it's a little bit of that athlete's mindset. Really got interested in that for myself, for my performance, for my longevity. How can I use what I'm using for my patients to make myself better? How can I use what for myself to make my patient's journey better? And that's where it really started with, okay, let's get them optimized before they come on a cellular level. It could be their oxidative status. It could be their nutritional status. There's lots of things we can do to get them ready before they come. But then it really gets heavy in the period right after surgery, when they're with me for a week. Usually it's a week, sometimes two. And that is where it's really fun, and you get to be creative, and it's very unique to be able to do things like hyperbaric oxygen and LED light, red light therapy, and pulsed electromagnetic fields, all of which have really strong scientific data behind them as well.
So when you are evaluating a patient preoperatively and when they come to you and you're assessing sort of their nutritional status.
Yeah.
I mean, that was your major in college.
There was, yeah.
Nutrition.
Mm-hmm.
What tests are you drawing? What are you getting? What are you looking for to sort of determine what do I need to supplement this patient with before they get into this operation?
Yeah, that's a beautiful question. Most surgeons are drawing labs before surgery at some basic level. Interestingly, now I'm finding that a lot of my patients already have this, and that is a full functional medicine panel that may include even some toxins. There's a few key things I'm looking for. Some basic ones would be like vitamin D. We know without question that vitamin D status leading into surgery is one of the greatest predictors of a postoperative infection, right? Any procedure, doesn't even have to be surgery, right? So those would be some very, very basic things that I'm looking at before, but it often is coming with a full functional medicine panel, I would say, and often with some genetic testing as well. So I'll know how they methylate their B vitamins before they come, which then helps me in their postoperative period design their IV infusions that they're going to get afterwards to be very specific to what their nutritional status is, or their methylation status, or whatever that may be.
So you've incorporated personalized or precision medicine in the area of facial plastic surgery.
Yeah.
Which again, I mean, come on, let's be honest. Most surgeons don't think that way.
No.
Do you find that the patient is more compliant with understanding nutrition, and may even their experience with you may even lead to a little bit of a life change in terms of how they treat their body?
Very well said. Yeah. And I love that part of it. And some of my other patient stories definitely get into those things that have very little to nothing to do with their results from their procedure with me, but a lot to do with changing their blood glucose path that they were on from an insulin resistant standpoint, finding out you're really quite insulin resistant, and putting them on a continuous glucose monitor in their time leading into their procedure, and then them getting a sense of what that does for them. And I love those parts of it, and it's funny, I kind of tease some of those patients when I see them in follow-up, when they're they've lost weight at that point or whatever it may be, and my blood glucose is under control and I'm not insulin, and I'm and we're celebrating that, and I'm well, look at your result too, it's so good, you know. And so kind of always a little funny joke about these different parts of it. But I think there's a bit of a selection bias, meaning that the people that are coming to me may already have sort of a predisposition to be interested in these things, which is how they're finding me a lot in the first place. They're just resonating with my message. You have to have a surgeon, especially in a situation like this, that you resonate with.
So there's a lot of physicians out there who have sort of taken courses over the weekend or taken courses for months at a time to do aesthetics.
Sure.
Right? What is your opinion about fillers and Botox? What's the truth about fillers?
Yeah, I think that they're highly misunderstood. I don't think that they're bad, and I don't think that the people that are using them are bad. It has increased a lot. It's become much more commoditized. That's a perfect word to describe how it goes. What happens is these newer injectors, and a lot of injectors who have experience just don't understand these very well. Fillers are a prime example of this, because it's a very easy entryway into anti-aging. You put in this gel, and what you're told is it's temporary, it goes away, it's harmless. If you don't like it, we can just dissolve it and get rid of it. And none of those things are actually true. The thought that it lasts 6 to 12 months is based off of FDA trials of correction, not duration in tissue. And I see in the operating room every single week filler that is decades old. It does not go away. We're not talking 6 to 12 months. We're talking decades. That's how we should be measuring it, right? What happens with the 6 to 12 month mindset, which is pervasive, is that you get some, and then you come back in 6 or 12 months and you get more, and then you get more, and then you get more. And what happens is you have these little micro shifts in how you look. And we've all seen what the end result of those micro shifts can be when they're consistent, is people stop looking like themselves. But to them, gets very neuroanatomical. The way that their perception drifted slowly over time is they didn't see the drastic change that other people around them can. So I see that all the time. All of a sudden, I saw my sister and she said, "What happened to you?" And I didn't even notice. Then I looked at old pictures of myself. There's some inflammatory components to the filler. It migrates. There's just a lot of misunderstandings about what it does. It's not harmless. I also don't think it's bad. It just needs to be looked at as, for all intents and purposes, a semi-permanent implant once it's put in. You don't need to keep getting it over and over again.
What's in filler? Like, what is it?
So filler is, the one that most people think of first is hyaluronic acid, which is a natural part of our extracellular matrix of our skin. It naturally exists in our body, and it is taken actually from a bacteria, but same structure, and then it's cross-linked. The cross-linking makes like this gel, and different gels have different properties. How dense they are, how long they last, how structural they feel. And then they get injected through a needle or a cannula into places that have lost volume. There are other fillers, that's the main category, but there's another category of fillers that people call biostimulators. And those would get injected and they would stimulate a response to, it's generally a foreign body response actually, to build more collagen. You hear that a lot in aesthetics, building more collagen, which is very false logic and misguided at baseline because the collagen that we're building is essentially scar tissue, for lack of a better term, or fibrosis around a foreign body, and that's not always what we want. So that's the category of fillers. And again, what I just said makes them all sound very bad, and that is not the case, but those true properties of them need to be understood by the people that are using them, and they're either not understood or denied often.
What could somebody do instead of filler? Because for me, when you're talking about it, I'm like, why don't people just do fat transfer or something? Like for me, that's the first thing that comes to my head.
Right.
What?
So I like to get to the root cause of what they're trying to do with the filler a lot of times. Sometimes filler is transformational. And I would categorize that as the 19 or 20-year-old that comes in to get filler in their lips because they want to augment them, which would be very similar to, say, a breast augmentation, transformational at that point. And so there's that category of filler, but then there's the anti-aging group. That's the most common. And okay, so what are they trying to do? They're trying to add volume back to the face. What you just said about fat transfer is an alternative option that is regenerative. It's autologous, meaning it's from you. It's replacing like with like. There's a bunch of really good things about that, but it's also very challenging to do it well. That would be my first answer for an alternative as well. Let's replace lost fat with fat. I use this perfect/terrible analogy of breast tissue. Everybody can imagine as the breast is a fat pad, and what happens with time, it's not just the size that changes, it's the position and the orientation, right? And so if we wanted to rejuvenate that fat pad, any fat pad, you're not just trying to add volume to it, which is what filler's doing. You would not add an implant to an aged breast. That would make it look odd. So instead, we're just trying to well, let's get the structure back, let's put it back in place, and let's make it project in the right direction again. And so those would be my main alternatives. Fat transfer being at the foundation of that for sure.
Talking about Botox, what's your opinion of Botox? How does it work? Let's assume we're talking to 7-year-olds here, and we're trying to figure out what is it doing to the face?
Botox paralyzes muscle. That's the 7-year-old answer. Paralyzing means making it not contract. The way that Botox has worked historically from a cosmetic standpoint is it makes the muscles of our face not contract or not contract as hard. And that puts some relief on our skin surface because when we make a facial expression, we put tension on our skin, and over time, repeated tension breaks our skin down. So it's this little tug of war that's happening between the muscles and the skin. And as we age, the muscles kind of start to win. The skin gets weak and it doesn't stand up to the force as well. Because when we are 19 years old, we're making a lot of muscular force, but our skin is just resilient and stands up to it. Addressing this tug of war, we can make the skin stronger, which, spoiler alert, is my main answer. Let's make the skin stronger so that we don't have to alter the muscles as much. But if we weaken the muscles, we have helped the skin not break down. That's why getting Botox before we have a lot of wrinkles is a better preventative treatment than taking somebody who's 70 years old with a lot of wrinkles. I think people think you put Botox in that person and the wrinkles go away. At that point, the structure has changed. You're only going to, weaken the muscles. If we really take it one step deeper, then we get back to root causes. Why are our muscles expressing in our face? What are they doing? Well, this is one of our main routes of communication. There's a bunch of functions to that. Sometimes it's squinting from the sun, sometimes it's communicating. And so I would question really, do we want to take all of those muscular actions away? People will argue, well, you're not taking them all the way away. You're weakening them. And that is true. So you may not completely take your ability to emote or express or communicate away, but you're taking some of that function away. So I'm not against Botox. I am more sort of like very middle of the road. I think it can be a really great option. But I really like to think of, well, what are we trying to do here? Instead of using a bunch of Botox, well, maybe we can use less of that and strengthen our skin at the same time and equalize this tug of war a little bit more.
How do you strengthen the skin?
You can do anything that, from microneedling. I like microneedling with regenerative medicine, through lasers and things like that. And then even if we get to this level, like I don't think we're going to talk a lot about topicals, and I don't love topicals. Big tip is retinols, which is a vitamin A derivative. They truly act like a hormone. They translocate into the cell, into the nucleus, and they change DNA expression to help upregulate collagen and elastin. That really becomes important as people's sex hormone levels stop dropping, primarily estrogen, but as those levels drop naturally, say as someone becomes perimenopausal, those levels drop, the amount of collagen and elastin that our fibroblasts create drops, and we can get around that, biohack it. I love this is one of the true biohacks of putting a vitamin A derivative on to those cells and upregulating. And that can be a great way to strengthen the skin as well, just with a topical. But that's a long game. You got to be consistent with that.
From a nutritional standpoint, what would you tell people to eat?
I mean, I'm going to say whole foods if we get into that, right?
Yeah.
But it's different at different ages even. And this question comes up with like an acne-prone teenager as well. It's like, okay, well, let's look at what type of inflammatory foods you might be eating. Not that that's the only source, but it definitely contributes to the systemic inflammation, just like you would do if somebody was having significant gut issues, gut inflammation. This gets very into functional medicine, right? Is like the skin and our gut are very, very connected.
Yeah.
But then as we get into our anti-aging, that's where I'm going to say, same things. Just want to focus on your overall health, inflammatory status. So it's going to be like low inflammation foods, whole foods, getting enough protein. If we really want to get into the micronutrients that are important, we get into zinc and copper and magnesium. And some of those are just part of the true structure of collagen. It needs those.
So I want to call this section face off.
Okay.
All right? I want to have some fun with this rapid fire face off section. All right. What inspires your aesthetic eye outside of medicine?
Ooh, I love architecture and nature. It's very different things. Nature has these kind of fractal patterns that exist in it. I live in an area that's very mountainous, a lot of lakes, and very data-driven now, actually. We know that changes the way that our brain reacts, functions, and how resilient we are. So I like that for that reason. And then if we get into like other more design-based things, I really love architecture. That's like my thing that I would geek out on a little bit, that is very like human-created but artistic.
I think this goes into the next question then. If you weren't a surgeon, what creative field would you be in?
Yeah, I think architecture would be high on that list. I probably would have been an athlete, and then I probably would have been a photographer of athletes. I always say like a surf photographer. So I'm like out in the water, creating in these special moments in this very unique setting.
What's your favorite procedure to perform?
Eyelid surgery.
Why?
Eyelid surgery is the most subtle when we get to overall results, but also the most impactful and least invasive thing that I can do for most people to completely achieve that thing that they're after. Like make them look bright, youthful, energetic with like also no change. If you saw them in the room, you would never know they had anything until you saw their before and after photo. Which was my jam. I love that.
Is there a celebrity out there where you're like, man, I could really do some good things to that face?
Yes. Keanu Reeves, I believe, recently had a procedure.
Yeah.
I mean, he looks good. But when I look at the nuances of it, I think like, oh, these are the things that I'm really careful for in a guy, which is that he got a little bit feminized and it changed his character a little bit. He was a very handsome, very distinct. His eyes were clearly a distinct feature of his, and they got changed a little bit. But at the same time, I'm in the 1% that recognizes that. The other 99% of people walking around are like, looks great. So.
And who's the other one? I mean, female.
I like stay so far away from celebrity stuff.
Okay, fine. Look at my eyelids. Are my eyelids fucked?
No. Your eyelids look great.
My eyelids
So
look
here's
great?
the thing. How about this one?
Okay.
Let's get into a female actress who is like stone cold, absolutely undeniably and universally beautiful. Sydney Sweeney.
Okay.
Who has strong connections to where I'm from. She's beautiful, but she has ptosis in one of her eyes, where there's asymmetry to the eyes. One's a little bit droopier than the other. And so here's a great question is, should that be fixed? Like I look at it and I'm like, I could make her eyes like bright and symmetrical, but would that change Sydney Sweeney and make her not who she is? And, I don't know that there's a right answer to that, but I definitely have patients like Sydney Sweeney at her age who are beautiful and seek like this little change that is like, well, some of that is maybe gets into the transformational part, and some gets into like, well, that's just, gotten a little bit worse with age.
I don't think that most surgeons would ask that question when they're taking care of people that are on camera all the time, is thinking about the uniqueness that makes them the characters that they portray in a film or in a commercial or on a TV show.
For sure.
So it's interesting that you would kind of almost think about it. Like,
Yeah.
hey, wait a second. Would that change your complete look into why you get XYZ? That's interesting.
Yeah, and it's kind of like we teach our kids all the time. Just because you can doesn't mean you should,
Yeah.
right? So that theme is pervasive in my practice, and I think about it with everybody. If I have a performer and we're talking about things on their like neck or lower face, I'm thinking about, okay, what's this going to do to your mouth and your muscular function around there? And there's a lot that goes into each individual person, and I get to have those relationships. So I get to know those things.
What's the most overrated trend?
Filler. For sure, 100%.
100%.
No question about it. I would say of the inquiries that I get, 95% have some filler history. It's one of my main questions.
Yeah.
There's a group that the filler is problematic. It's like the main thing we're really trying to deal with. And that's the minority of this group, but it's probably 20%. Like your filler is just a problem. We have to take care of that. And then there's a group where we're doing a bunch of things and the filler that they do have isn't great. It's not terrible. It's not ruining them, but it's also suboptimal, I would say. And so we're addressing that as part of the overall procedure. And then there's another small minority, the two bookends are the small ones where they've had filler and it's just, sort of present, but not causing any big issue. And there's nothing we really need to do or think about with it. I still see changes in all of those groups have changes in their postoperative recovery because of their filler, because that filler changes the way that they have an inflammatory response and it changes the way mechanically that their lymphatics drain.
Oh yeah.
So they have swelling for a longer period of time. It's just like a conversation up front. We know this is going to happen.
Wow. How do you normally dissolve filler?
Yeah.
What are they telling you?
So you have let's just start with the ones you can't dissolve. And those are the biostimulators, right? The ones that stimulate collagen cannot be removed, or one of them is something called calcium hydroxyapatite, which is a component of bone, right? Those cannot be dissolved. Then you have the group that is more common. Those are the hyaluronic acids. There's an enzyme called hyaluronidase that we make naturally too that breaks down and turns over. It's used in ophthalmology and it's off-label, FDA in the United States, off-label to use to dissolve filler, but it's an enzyme that it is meant to break down hyaluronic acid. So it sounds like this like get out of jail free card, this magic wand, right? You just like, oh, you don't like it? Boom, I'll put a little enzyme in there.
Done.
The problem is the fillers are meant to be hard to degrade. They're built that way because we don't want them to be put in and go away. And we know that they're very good at not being broken down because they last decades. And so to think that you're going to bathe this giant ball of filler in a little bit of an enzyme on the outside that has a relatively short half-life, you may like dissolve some of the outside, but the center portion is still there. And then the enzyme itself breaks down our natural hyaluronic acid, which if it's in small doses infrequently is fine, but I have seen it used over and over and over in high frequency, high volumes. And then it causes changes to the native tissue around the filler, which now you're like really walking backwards.
What's your best recovery tip for patients?
Hyperbaric oxygen, hands down, hyperbaric oxygen. It's strongly data driven and it's the best thing you can do to help you recover from any surgery. It doesn't have to be what I'm talking about. It could be a knee replacement, a hip replacement, could be anything. Hyperbaric oxygen.
Yeah, we used it for healing a lot in the hospital and people who were, I think, burned and things like that.
Yeah.
A technique or tool you're most excited about?
I'm really excited about progressing through my minimally invasive, I call them invisible access types of, let's call it like a facelift for lack of a better term, but being able to address and lift somebody's entire face through a small incision hidden up in their temple, which I do often. And I'm expanding my use to different age groups. It's traditionally been used in like a younger age group, younger being 40s, late 40s. And that's like definitely a front cutting edge type of thing to do.
The biggest misconception you'd erase if you could?
Having surgery, the types of surgeries that I perform, that they're going to make you look different. Quite the opposite. My job, my goal, our entire conversation revolves around making you look like yourself, just rejuvenated.
Have you ever had somebody be like, bro, you're supposed to make me look better. I look just like I looked before.
I have had those things where it's funny. People say it all kinds of different ways, like we're all on an aging curve. And so I usually use this analogy that the curve is flat and then it starts getting steeper with time, which has a bunch of biological, sort of reasons, but I'm just trying to slide you back up your aging curve. I'm not trying to move you off it to a different degree. I just want you slid back up and then I want to flatten the curve forward from there. And that's where the regenerative medicine comes in a little bit.
Ever had a patient outcome that you're surprised by?
Yeah, I mean, always. It's always a little bit of that. I have this practice where right after my procedure's done, we all write a medical note, right? Like, here's my note. But then I also go by myself, usually in a sauna, and I sit and I have like this deep reflective time of like, okay, what did I do today? What decision points did I make that were branch points that were a little bit unique, that were the micro decisions that we all make? And then I write this little procedural journal to myself. And it's a journaling exercise, so there's benefit in that. But then what it really serves me well is 6 months later or a year later when I get my results from that procedure, because I don't get them for a while. Like I get to walk them through the process, but I don't actually get like the fruits of that. And then I have this moment where I call it like watching film, like you would do after your football game, right? Like, okay, here's what I have on film or on photos. Here's what I was thinking at the time. And I start matching them up. That's where the little micro surprises come all the time. And that's where I kind of get these 1% evolutions all the time, is driving like, I made this little decision. How did that turn out? Oh, okay, I learned something. Let's move on.
Now, you're a nice guy, so you have a lot of loved ones, but have you ever performed surgery on a loved one or yourself?
No, I have not.
Would you ever do that? Or are you like, no, I'm not you're going to have to see my partner?
A loved one gets extended, but I've performed procedures on people that I love. How about that? But no like immediate family type of situations. On myself, that's an interesting question. Has anybody ever said yes to that question?
You'd be surprised.
Like a little appendicitis or something? Yeah.
Somebody take out liposuction.
Right. Yeah, there you go.
Has your wife ever said anything to you? Like, babe.
She teases me all the time because I now have patients who are my wife and my age. And so she's like, and my wife's beautiful. And anytime she asks me something, I'm like, you don't need anything. She's like, you're just saying that to me because I'm your wife. If I were in your office, you'd find something to, so I have to like sit back and I'm like, is that true?
That it's going to be an issue the one day you actually say something. You're like, sure. Babe, we could do this. She's going to be like, what?
Yeah, right, exactly. I got to let her bring it up. She's far from it at the moment.
What procedure gives the biggest confidence boost? Is it the eyelids?
Yeah, I think this goes back to eyelids. When we get into how we perceive beauty and how we perceive faces and emotion and communication, we have very specific brain regions that are targeted on the eyes, right? They say they're the window to our soul, which is cliche and cute, but true. Like we use them to judge somebody's trustworthiness. We use to judge how they're communicating, what their current emotional state is. All that means that small changes, and that's what we want, small changes in the eyes can have very impactful results to how you're perceived in a normal, communicative, like real world environment. The funny part of this is it's less common that somebody comes to me and says, I want my eyelids taken care of. That does happen. Much more common is, I don't like what's happening in my neck and my lower face, which is further down the road. But this gets into a self-perception versus how we're interpreting and communicating with one another. And in self-perception, we get very analytical. We go to different neuroanatomic areas of our brain, a lot of frontal cortex, prefrontal, and we're looking at like, oh, this is blunted and this, but you haven't looked at my neck all day. You have no idea what it looks like, but you know exactly what my eyes look like because that's how we're using them.
Yeah, I think you need to do eyelid surgery on yourself.
There we go. But yeah, that's why it's my favorite.
I'm sure you've operated on Black patients, white patients, whatever. What are the differences when you're doing little minute procedures like that? Because I know as a Black patient, when I get a scratch or knife, I really get hyperpigmentation. So how do you treat them a little bit differently when you're operating on?
Yeah, this gets into skin type, but also just any other sort of like health history, because some people have propensities with any injury to have an inflammatory condition arise at those areas as well, which is what's happening with the hyperpigmentation. It's called post-inflammatory pigment change or post-inflammatory hyperpigmentation. You can manage that. Part of the beauty of what I get to do is that the incisions by definition are very well hidden or invisible. So it tends to be less of an issue, but we start talking about lasers. How about that? And this is a beautiful conversation because it brings us full circle back to the first thing that I said, which is like, let's address the skin. Well, we have to think about that differently based off your skin type. I have patients, who are of Asian descent as well, like all the spectrum of what we'd call the different skin types. And you have to think about treating those things differently for the exact reasons that you said. There's anatomic changes in like eyelids. We talked about eyelids. And so like an Asian eyelid is different than a Caucasian eyelid. And that gets very in the maybe nuances, more so of these like even baseline things, which is like, you want to treat your skin. That's the first place to go for everybody. Okay, well, you have to think about that differently in different skin types.
When you're bringing this artistic eye to your work, you're thinking symmetry, or you're thinking, this person's got a little bit of extra fat here. I can manipulate the way you see it by doing X, Y, Z. Like, what is that?
Yeah, it's really putting different facial regions together. There is, even in the artistry of it, there's some mathematics of the golden ratio and things, and those actually hold true, again, back to the neuroanatomic things. But this is why I love to really dive into those neuroanatomy, because it helps me to understand more of the artistic subjective nature of how we perceive faces and beauty. It's like my main motivation to do that is which minute levers can I pull artistically to make make change, to have improvement, and have things still look natural. So symmetry is a big one. Nobody is perfectly symmetrical, so it's an unachievable result, but I'm often looking at those things, especially in the eyes where we're a little bit more sensitive to it, or in the mouth. We have a lot of attunement to the mouth as well, which makes sense because it's another communication tool. I really try to get into the artistry. Like, I don't want to be overly subjective with what I'm doing. And I try to, like, again, when I'm speaking to patients, sometimes I try to make it overly objective of like, I'm taking this fat pad and I'm moving it back where it came from. And I can see the home where it used to live. Not to take the artistry out of it, but that's kind of how I stay objective about it. And now once the fat pad's back home, then I get, okay, how big is it supposed to be? Where's it supposed to point? What's the structure and function of it? And then that's where the artistry comes in a little bit.
So as we age, our face loses volume, which it's losing fat. Is that correct?
Correct. Yep.
A question I have with that is, as you lose the volume, if you're going to go borrow fat from somewhere and you're going to replace your volume with fat from somewhere else on your body, I mean, how do you know it's going to get the blood vessel supply?
Yeah.
Make certain it gets the blood vessel supply. How do you make certain it stays alive and it doesn't just dissipate on its own? How do you make sure that the graft that you've placed stays?
So 2 important conversations I think come out of this is, number one, the volume loss theory of aging. Not theory, it does happen. But I think that volume loss gets a lot more credit than it really is contributing to our aging. That's where filler becomes problematic, because that's the only thing it's addressing. And some part of our aging is certainly from volume loss, but it also goes back, think back to that breast tissue. It's not just the breast lost all of its volume, it's that it changed shape and orientation, right? And our face does the same thing. So gravity is playing a key role now as well. So sometimes just putting the fat pad back and restacking the volume that's already there, it actually isn't as small as I thought it was. So that's part of the equation, right? So that was point one. Point two, this is a very nuanced question because you're talking about, it's a graft at this point. It's being taken from one location, no blood supply, put to a new location, and then it's got to survive. So there's a few strategies. This is a very, introspective question on you. It's a good one. Part of that is taking the stem cell dense fat, because the stem cells drive the creation of new blood vessels, which is a fun name, angioneogenesis, right? The stem cells orchestrate that in any fashion. So if I'm transferring very, very stem cell dense fat, it is very good at orchestrating that. There's other things I can add to the fat, like PRP, our own growth factors, or exosomes, which we mentioned briefly, that have also been shown to help it. But then this is where some of that recovery really gets into it as well, is if I've got really stem cell dense fat, I put it in the right location, near blood, like all the things that we want. Our face is very vascular, so it does really well there, as opposed to like breast tissue, which doesn't do as well with fat transfer because there's not as great of a blood supply. Our face is beautiful for that. It does really well. And then I put them in a hyperbaric oxygen chamber afterwards, which helps upregulate and create more angiogenesis, take some of the metabolic stress off of it. So I do a lot of things afterwards to help that fat take better too. And that's very, very evidence-backed also.
When you talk like that and you communicate a lot of different scientific terms, I think of you as a scientist. I'm going to ask you this question and I'm going to make you answer it. How much of facial plastic surgery is science and how much is art?
1/4 of it is art. I think 50% of it is very basic science. And I think the remaining 25 is very progressive, the type of science that is evolving heavily.
For a patient to come to you for an operation, it's not just an operation. It's like an entire, I don't know. It's like
an experience. It's an
experience. And so what do you wish every patient knew before that surgery?
I wish that everybody had a really good grasp on like what the outcome is going to be, right? We're going to be rejuvenated, which I'm pretty good at that. So that usually happens. I wish everybody had a really great grasp on what the recovery process is going to look like. And so I work really hard to do that as well. I think that's one of the biggest misconceptions that I hear. And I hear this as almost like a marketing thing a lot of times is, oh, it's 2 weeks of recovery after let's say a facelift, right? One of the longer recovery things. Oh, it's only 2 weeks of recovery after a facelift. And anybody who knows anything about wound healing knows that that's not true. Yeah. You can't have a cut on your leg and have it healed in 2 weeks. That does not happen, right? And so I think that sets people up for disaster, both the surgeon and the patient, because it's an unrealistic expectation by definition off the get-go. It's different when it's on our face, right? If you have a surgery on your abdomen or something, you put a shirt on and nobody can really see what's going on. But when it's on your face, it's hard to hide.
Each patient that comes through you, that goes through you, they have their special, personalized, precision medicine-based plan before operation.
Absolutely.
Are there elements of that plan that are pretty common for everybody? Like, everybody's going to have probably these two things.
Oh, yeah, absolutely. The functional medicine piece, the laboratory values, the genetic information, if we have it, those help me to really customize or microadjust what's already going to be happening anyway.
Yeah.
And that could be, everybody's getting hyperbaric oxygen.
Yeah.
Everybody's getting red light therapy.
Yeah.
Everybody's getting on pulsed electromagnetic fields, which is a way to help healing. Everybody's getting IV nutrition. That's a really easy one to sort of adjust. And so I would say, again, it's just micro adjusting the things that are already very foundational that are happening.
One of the things that Cameron describes when he's talking about his surgeries is he talks about, I'm going to injure your face. Like, right? He says, I'm going to injure your face,
Yes.
which means he's going to create inflammation. He's going to stimulate healing. And you guys know that I've always talked about this, is the way your cells communicate is really what leads to a disease process or a healing process. And so when your cells are communicating, they have to be able to operate efficiently and effectively. And they do that with vitamins, which are vital to your cells, so your cells can operate efficiently and effectively. And then there's other molecular biomarkers that get released from cells and activate an inflammatory response, activate a healing process. And so what Dr. Chesnut or Cameron is trying to do, or is doing, is making certain that when he injures your face, you heal in the most positive way possible that gives you the results that you wanted.
Right. We can't stop the inflammatory. We don't want to stop the inflammatory. And people do that all the time. They stop the inflammatory process. It's very common in my field that somebody will give steroids post-operatively, right? Which are just a blanket to stop all inflammation. Or even just like an NSAID, anything that's inhibiting the inflammatory cascade, that's a terrible idea. That's incredibly flawed logic to me, because we need that to happen to make new blood vessels, to make new collagen, to make new elastin. Can you imagine shutting down your angiogenesis immediately post-procedure? Your outcomes are not going to be as good. It's a comfort crisis. One of those things I said is I like to slide back up the curve and then I like to blunt the transition ahead. I don't want it to be as steep as it would have been otherwise. That helps me get better long-term results out of things. And one of those things is we have to have a strong structural healing curve to make those things happen. Things have to stay put once I put them there.
So how do you explain that to patients? Like, what do you say? How do you explain to them, hey, listen, there's going to be a benefit of this nutrition plan I'm giving you before surgery. These are the things that you're going to eat. These are the IV vitamins I'm going to give you. And the reason that we're doing that is to get your blood vessels ready to grow for angioneogenesis. We're going to do that so your enzymes operate optimally. We're going to do that so your white blood cells move effectively and efficiently. How do you explain that to them?
A lot of my patients sort of speak this language a little bit already, but I kind of tell them that, everything meets in the mitochondria a little bit, right? That's the energy cells of our body, of each cell, or excuse me, the energy source of every cell of our whole body. And so all the things that I'm doing are really focused on trying to optimize what's happening there to create that energy to help that healing. And that's true for red light therapy, and it's true for nutritional status and the IVs that they're getting afterwards. And I want them with that optimized coming in as well. And so once I kind of get into this, like the inflammation is good, it's how we heal. We want it to be bright, be brief, and be gone. We want it to come, do its thing, do it really well, and then go away quickly. But we want it to be complete and comprehensive. That starts to resonate a little bit. It's like, oh, okay, yeah, of course it makes sense that we need to heal after surgery, and we don't want to just blunt that all the way.
Peptides before surgery?
Yeah. This is a great question. A peptide is a very small chain of amino acids, right? Some of these are like literally 3 amino acids long.
Yeah.
So not a complete protein. There's some that help with the inflammatory part. There's some that help with blood vessels. And these are things that many people, if you've heard of peptides, you've probably heard of like BPC 157 or thymosin beta 4, TB 500. Those are natural and synthetic versions of the same thing. Those two are really great in those categories of helping to create new blood vessels and helping to control or support the inflammatory process, not shut it down necessarily.
Now, when you look at this cell communication science, right, when you look at these peptides, when you look at certain proteins, when you look at vitamin supplements and all of that, the literature isn't as robust as therapies because medicine is typically reactive.
Right.
You get sick, we give you this, we know that it reduces mortality or makes you feel better.
Yeah.
Not a lot of time are people studying supplementation where it's like, well, actually, if you're eating whole foods, you're doing all of this, it's going to lead to better outcomes. We all kind of know that. But occasionally I'll have patients that will challenge me and they'll say, well, there's no clinical studies on that. Why are you telling me to do this, right?
Yeah.
How do you handle that? What do you say to your patients?
Yeah, this gets into actually, if I go back to that question about science and art, this is the 25% I was talking about. That's like this more emerging science, because there are decent studies and there's some data about peptides. It's not all human. So we sort of have to start weighing risk and benefit of those things, right? Which we're doing all the time anyway. But this applies to, like, I have my patients take creatine, right? Which there's little to no evidence of creatine for specifically what I'm doing.
Yeah.
But when we get into the mechanisms of surgical recovery and what they're doing, it starts to get very clear, even from a cognitive and a sleep standpoint. I'm very into my patients' sleep afterwards. I have them take melatonin. They start the night before. It has some to do with their sleep, but also has to do with melatonin has some inflammatory modulation profile, right?
Yeah.
Which I don't think
COVID in the beginning. Right? I used it a lot in COVID.
Yeah, and I don't think a lot of people know that, right? And so these are things that definitely fall in this, like, no direct evidence to what I'm doing, but I can certainly tie strong mechanisms together to my goals. Some of this is back to meeting in the mitochondria. And so I live in that space and I'm fine there. And I enjoy it, actually. And that would be just a conversation to have with my patients about those things.
Yeah, it's super fun to have the conversation. I think it does require a little bit of teaching on our part to get patients to understand the science of how the body works and cells communicate and all of that.
Yeah.
But it seems like you have that conversation and you take advantage of that mechanism, which leads to kind of your specific post-op regimens that you tailor to each patient.
Yep.
Because you said that they stay with you for about a week. Is that right?
That's
post-operatively?
correct. Yeah.
And what's the recovery like? So if you operate on Monday, the patient's going to stay until Friday or through the weekend?
I see them about exactly 1 week after their procedure. And it's pretty predictable that for the first 4 or 5 days, people have a lot of acute swelling, and those are the hard days, if you will. And so one of my team members who's in their surgery goes home with them after the procedure, staying with them. So it's a very concierge type of setup, which is nice. That person was in their surgery, so kind of knows all the details. And it's very supportive for those first 4 or 5 days. We see them every day. They're with us for, it takes a while to go through this recovery protocol. There's a lot of emotional support that goes into it.
Yeah.
And then after like 4 or 5 days, people are like, oh, sort of out of the woods. I can see the light at the end of the tunnel already, which is a very normal process.
I wouldn't be doing my job as a pulmonologist if I didn't ask this question. Patients with chronic lung disease, COPD, asthma, is their recovery any different?
Yeah, it is. I don't work on as many of those patients because of, just the nature of the types of procedures that I'm doing. But when we get into just like even reconstructive types of nitty gritty, absolutely, right? That's has to do with their oxygenation, their inflammatory profile. Getting into those patients, we have to be careful with hyperbarics with a lot of them, but that would be a huge benefit to them in those settings as well.
Yeah, because there are certain things that might help with healing, but that could hinder their lung,
Absolutely.
like ozone and things like that. If somebody has controlled asthma and say they're on a biologic, say they're on a medication that specifically inhibits certain cytokines that we know contribute to their asthma, and I know you know this because you pay attention to cell communication. Are those patients you're not operating on because you don't feel like their healing process would be as optimal?
You know what I'm doing? I'm calling you.
Yeah.
Truly. And we're going to have a conversation about, like, I want a deep understanding from you of your most current knowledge of what the wound healing looks like, the infection risks, because I do understand and I love cell communication, but I want to know from you who wrote it, like what you're thinking about it and how we can adjust dosages. And a lot of times, honestly, we don't end up having to do it, but I want to have that conversation beforehand. Yeah.
Yeah. I mean, I think, just in general, for the most part, when you look at biologics that inhibit specific cytokines, any of the cytokines that you kind of indirectly mention in your practice that contribute to wound healing aren't those cytokines that we're actually inhibiting.
Right.
It doesn't mean that there's not an indirect effect of
right.
cytokines,
And
but it is an interesting conversation to get into.
There's a butterfly effect to it for sure.
Where is all this headed? Like what's next in facial plastics?
There's a lot of drive into the regenerative space, which is one of the things I'm talking about here. I'm definitely at in our field, definitely the biohacker, which I don't love that word. And I don't
disruptor.
Use it. Yeah. Well, not even, I just that's what I'm known for.
Yeah.
And personally and for my patients. Right. And so I think a lot of things are going that way. People are very curious about it. That 25% again of the more evolving science, which is great because it's going to improve our patient outcomes. I'm a big advocate of a very neurocognitively protective anesthesia protocol. which I have, again, this is a luxury. I don't have to put my patients under general anesthesia. They're not intubated. They don't have a tube in their throat. And that allows me a lot of room to be able to do different things with their anesthesia.
So how do you sedate them?
Well, I don't use any benzodiazepines and I don't use any opioids, which is the normal, right? Fentanyl and Versed, everybody gets those. So I don't use any of those. And so I'm using things that are like, one of my main ones is a central acting alpha agonist called dexmedetomidine and Precedex. And that helps them sort of control levels of, let's say, consciousness, right? Has no pain control though.
Yeah.
So that's where my job comes with just local anesthesia to do my pain control. And I'll mix in a little bit of ketamine, and ketamine is very dose dependent, right? At low doses, it can be very neuroprotective, like anti-inflammatory from a neural standpoint. At high doses, it can switch. Right, exactly. It's all based off neuroinflammation. And that's where the understanding has led. And so I'm using things that are neuro anti-inflammatory. Even the things like hyperbarics afterwards are helping that neural inflammation from the anesthesia as well. And it makes, again, back to the recovery experience, it's a very pleasant recovery experience. There's no fog, there's no nausea, vomiting. It's all controlled in ways that don't require any opioids, benzodiazepines.
And I see you spend a lot of time with your children. You have three?
3 children, yep.
How do you incorporate what you learned in college, medical school, and in your own research into what you teach your kids in terms of what they're eating, how they're exercising, all of those things?
Trying not to make things a battle, but then just trying at home to be a good example of what we're doing and educating them about why. And then letting them sort of like decide themselves and come back to it. Knowledge is power, right? Our kids, for both of us, get to start at where we evolved to, right? Which is pretty cool. I'm giving them the information. I'm treating them like, it's important to them and they'll understand it. As our kids get into sports and things like that too, I find that it kind of drives them back towards it. But, in my head, I know that, oh man, eating that cake at this birthday party is going to change your long-term insulin sensitivity or some, this is the fear in my head that you can't be the weird dad at the birthday party who no cake for you. So it's a hard battle, right?
But you're the weird dad at soccer practice.
I'm the weird dad
on the sideline doing your squats with the kettlebell.
Or just sprint. Or just
sprints.
Yeah.
That's right. He was sprinting around the soccer field.
Yeah, why not?
I love it. No, I think that kind of example is great for your children to turn around and look and say, I'm working hard out here on the sideline or in the soccer field. My dad is working hard. My mom was working hard out here outside. I think that's wonderful.
Yeah.
What's the proudest moment of your life?
I would say the proudest moment of my life is kind of like constantly evolving right now with what's happening with my kids. When I take this 30,000 foot view every day, I'm like, wow, I love my practice. I love what I do. I've got a great family and I have great patients, and that hasn't always been that way. I had this reflective moment years ago, a patient who actually didn't have a bad outcome, but just had a perception of something that wasn't real, basically. And somebody who just kind of made my life, just was sad. It was a sad interaction, a sad relationship in an area that I think I'm especially sensitive to. And so I made this pact to myself then. It's I'm not going to work with anybody from a surgical standpoint who I wouldn't want to be friends with forever. And which is bold. It's been the best decision I ever made in medicine.
Wow. When did you make that decision?
I would say that was 2021. So 4 years ago.
Wow.
Yeah. 4 or 5 years ago, right in that range. And so I've learned that there's no such thing as a perfect result in anything that we do. There's no perfect procedure. When I go into that surgery, I'm optimized. I've been paying attention to my sleep metrics and how my readiness, I'm as good as I'll ever be at that moment. And I give the best effort that I can, and I'm obsessed with what happens. But, in reality, every result's a 97%, 92%.
The public doesn't know how hard we work to be where we are at that moment.
Right.
How hard you work to get there. You slept well, you take into account this, you exercise, you do so many different things to optimize yourself.
Yeah.
And you just felt oh.
Yeah.
But you can't feel that way.
Right.
You got to plow through that. I want to end on a positive pulse.
Yeah, I love it.
Give me a patient experience or any experience in your life in which there was a positive outcome.
The one that just pops in my head as you mentioned this is a patient named Daniela. And I say that because you can follow her whole thing on Instagram, her whole journey. She's from Peru. She was 19 years old. And she got into a thing we talked about. This ties in our conversation a little bit too. She got into a filler roller coaster. Filler, dissolver, filler, dissolver, filler, dissolver. She was 19, beautiful. People would be she didn't need anything. But that's, it's her choice, right? She got it mostly in her cheeks and under her eyes, and the constant roller coaster that she was on caused a bunch of peripheral, just the adjacent soft tissue damage. So she looked very aged from where she should have been, and was distraught, understandably. Some people are distraught without reason and some are with. And at this point, she's 21 years old, right? Finds me from Peru. She ended up coming up and we did a very minimally invasive procedure to remove the filler. We did a very strong regenerative medicine-focused protocol to help restore the peripheral soft tissue damage, which was fat pad and skin, like showing blood vessels through her skin, paper-thin skin under her eyes, no cheek fat pads left, like not great. And now we're about a year and a half out from that, and she is just at a point where, kind of like that dream of you never know if she had anything done. Everything is back to regenerated to where it was at before, and she will forever be on a life trajectory from this point forward where not only does she have a new knowledge about it, but she probably will never, hopefully, really think about it anymore.
That's an amazing story, and I think it's why you do what you do.
Yeah.
Where can we find you?
Yeah, so Daniela's story and all those things, like there's a lot on Instagram. That's the best place to go. I'm on all the socials, but that's the one I'm the most active with. And anything you'd ever want is guided from there for sure.
What's your Instagram name?
It is Chesnut MD with no T in the middle of Chestnut.
Thanks everybody for joining. Really appreciate you guys being here. We're on Instagram at the Health Exchange Podcast. We are also on YouTube, Apple, Spotify, iHeart. Get us wherever you get your podcasts every Thursday morning. We'll see you then. Take care.